Yeah, you can share your screen, your
Okay, sir.
co-host now. Yeah. Good morning, all. Welcome back to Karnataka ENT Hospital Academic Program. That is Kent Academics. Today we have a very important topic, that is mastoid drilling techniques and hemostasis during middle and mastoid surgery. And this presentation will be done by Dr. Vasudha Singh, our otology fellow, the junior consultant at Karnataka ENT Hospital and the Research Center. Welcome you all for joining us regularly on this our academic journey. I hope this will be useful to you. Yes, Ma, you can start.
Okay, sir. Good morning, everyone. Today I'll be presenting on mastoid drilling techniques and hemostasis. I will proceed the topic under the following headings. First will be the basics of the drilling, then the Tegmen exposure, sigmoid sinus exposure, mastoid antrum landmarks, and opening of the antrum, exposure of the sinodural angle, exentration of the mastoid trip, peri-facial clearance, and hemostasis. Before beginning the topic, I want to share a nice thought which I came across in an Atlas of Temporal Bone Surgery by Professor Tunke Yuluk. He quoted in his book that as surgeons, we come across a lot of soft tissues, be a ENT surgeon or a general surgeon, but performing a delicate temporal bone surgery is a privilege of an otorhinolaryngologist. And he also compared the burr as the scalpel of temporal bone surgery. So we can realize how dangerous yet wonderful instrument we have for our temporal bone surgeries, and it can easily result in serious complication. And so one must undergo intensive mandatory training in temporal bone dissection laboratory to gain the ability to use this accurately and avoid any complications. So let's start with the tools of the mastoid drilling. First, the drills. Drills, these are the versatile tools. It can enable us to give a millimeter-wise drilling of the bone and keeping the delicate underlying structures intact. These drills, they have, like an ideal drill should have a property that it should be easy to handle. It should be lightweight to work with, so that the operator should not get tired with that, depending upon the surgery which is performed. And it should not give torque. The handpiece should not give torque while we are initiating the drilling, or we are means cessation at the time of cessation of the drilling. And the power or the speed of the drill is also a very important factor, because a high speed drill will provide us a efficient bone removal, and it will provide a wider and a complete drilling of the bone, and thus the penetration is less, the complications are less, which is not seen in the cases of a drill with a lower speed. So lower speed drills can also be used, but for delicate structures. But for efficient bony removal, we should use a high power drill. There are varieties of drills which were there. In olden times, we used to use a hanging motor drill. You can see the picture. This is a hanging motor drill. It has parts like motor, which provides a revolution speed of around 12 to 20,000, a transmission cable, and a foot switch. It is obsolete nowadays. It's replaced by the micromotor. It also has a hand piece, which is very heavy, and it has a screw stud along with a spanner, which was used to remove and insert every time the burr, whenever we required during the surgeries. So it's not used nowadays. This is a micromotor drill, which is seen in almost all the temporal bone laboratories, which is very good for carrying out the for dissection or during surgeries. It has following parts, like this is a console. It has an adjustable knob for providing a revolution from up till 40,000 revolutions per minute, a connecting wire to the handpiece and to the foot switch and the micromotor. This micromotor handpiece can be straight or angled handpiece, and we can use according to the situation. This is a latest drill, electric motor drill, which is used with the straight or angled handpiece. Just an update on this drills. So let's see the burrs which are used along with the handpiece or the drills. They are broadly into three types: the cutting drill, the cutting burr, the diamond burr, and an intermediate or rough cut diamond burrs. They are made up of steel, tungsten carbide, or titanium. Let's discuss the first drill, the first burr, cutting burr. It's very important and it's most commonly used during the drilling of the mastoid because of its specific design, which we can see the head of this burr has a specific projections which are called as flutes, and they are responsible for an effective removal or a rapid bone removal. And there is a optimum distance in between these two fluids, which does not cause any bone dust to accumulate, and thus the efficiency for the bone removal also is good in case of cutting burrs. The diameter of this cutting burrs can range from 0.5 to 7, and the length can be 45 to 70 millimeters. The action of this cutting burrs is like, they tend to, when we drill on a surface, they tend to open the air cell, and so we can see the bottom of the cell, and we can even appreciate the structures lying beneath it. And so disease clearance, if required, then the cutting burrs are very useful, even though we have to be careful about the pressure or the area which we are drilling, but the disease clearance is very good if we use the cutting burrs. The diamond burrs, which you can see in this picture, they range from a diameter of 0.1 to 7 millimeters and a length of approximately the same as cutting burrs. They function by, they make the surface of a bone very flat and uniform by transferring the bone dust. While drilling across a bony surface, it transfers the bone dust into the lumen of the cell, and thus it makes it smoothens it or saucerizes it. So it is used for finishing touch or for delicate structures where we don't want a lot of pressure or damage to the underlying structures. Then diamond burrs are used, and also it causes heating while it drills over the surface, and it also transfers bone dust to the bleeding vessels, so it can also act as a hemostasis in the drilling techniques. But the drawback is, if we used in disease clearance, then as I said, it causes the surface of the cells to become flat or closed, so it can bury any cholesteatoma in the air cells, and thus it will lead to recurrence of the disease. And sometimes the underneath structures which should be exposed in the surgery is missed because we have used the diamond burr. And obviously heating is an issue, so this burr especially requires copious irrigation more than the cutting burrs. First, it will cool this burr, and second, the tip will also not get clogged. So this burr requires more irrigation, and it is used mainly for the hemostasis and for the delicate structures. Another variety, rough cut diamond burr, it is an intermediate burr in between the cutting burr and the safety of a diamond burr. It is made up of diamond stone. Nothing in detail is I can come across in literature about it. So let's discuss as I told about the diamond and cutting burrs. The cutting burrs, they are quick, they cause efficient bone removal, and as it opens up the air cells, the operative view is clear along with the copious irrigation, and there is no overheating or excessive pressure issues in case of cutting burr. And the disease clearance is better in case of cutting burr, but we should not ignore the importance of diamond burr also, because it serves as a hemostatic during any bleeding things, and also for critical structures, any soft tissue damage. So these should be used according to the situation, and both are actually beneficial. We should not ignore any advantages of each. So the size of the burr size also determines the removal of the disease or opening of the cell. Like if a larger burr is used, it causes a wider drilling and it causes a wider exposure, and the penetration time, the penetration of the burr into the structures beneath, and the damage is less. So efficient removal and less complication are seen if we use a large size of burr. That's why most of the time when we start the mastoid drilling, we start with the large burrs, larger cutting burrs. Smaller burrs we can use, but the visibility, one more thing I forgot, and larger burrs thing is that they are efficient, the complication are less, but sometimes because of the larger size in some narrow spaces, the counter surface can get damaged, and also the visibilities also get compromised. So this can be overcome by a smaller burr where the visibility is good, counter damage is less, but we have to be careful because it has the tendency of penetration. So one must Apply no pressure or minimal pressure possible while drilling over the mastoid. Length of the burr also plays an important role in mastoid drilling, depending upon the depth of the area, whether you're working on the mastoid cortex or you're working in the canal. One should determine the length of the burr used. A shallow burrs usually used over the cortex, and the lengthy burrs are used for the canal. But shorter burrs, they have a better control than the longer ones. So one has to be careful about this point also. And the shaft, even though we always take care of the tip of the burr, but shaft can also catch hold onto connective tissue or skins of the area, various area or delicate structures, and can cause severe damage. So length of the burr should be considered whenever we are planning on drilling any part of the mastoid. So let's start the basic of drilling. So one must start the drilling with keeping these things in mind, like a high speed drill system should be there of at least 40,000 revolutions per minute. And the handpiece should be decided whether you want to use angled or a straight. Most of the time straight handpiece is used. The technique of holding a handpiece is also very important when we are carrying out a mastoid drilling. Let me show that first. So when you are holding this drill, you have to be careful that you should not grip it too high. Otherwise, the stability is not good and it tends to fumble around over that area. So one must hold it in a lower grip, and with the index and the thumb finger, even sometimes the middle finger can give a grip to the shaft of this burr. And also one should not obscure, like holding it very firmly. Sometimes people obscure the vision. So there should be a proper holding with a clear view. And so you can see in this picture, it provides if it is held in such a way, it provides a binocular vision. So once we are ready with the drill system, high speed drill and handpiece in a proper position like a pen, one must also think about resting their little finger and the ring finger, because as stable a hand is during the surgery, less will be the tremors and more efficient will be the work which we are doing. And whenever we are starting the drilling, we should not activate the drill whenever it is not in our vision. It should, in the microscope, in the site of the drill site, we should activate it. And as soon as we are done with the drilling part, we should stop or deactivate the drill. And we should always drill in a wider spaces, in layers, in a continuous pattern, and should not do in a discontinuous matter. And irrigation system is very important, whether we are using a cutting burr or a diamond, a suction irrigation system. First, the irrigation will help to cool down the burr. Also, it helps to clear that area, and suction also helps to clear that area. And the underlying structures are not at risk if a proper suction irrigation system is used during the drilling. A very important training is to see through the structures. That is, whenever we are drilling, we must train our eyes to see through the last remaining shell of bone before the actual exposure. So it can help us to avoid any underlying structure, delicate structure damage. And we should also train our eyes to see any subtle change in the color or structure of the bones. Also, we should see the difference in the resistance or the sound heard when we are drilling. So as we know, the different structures, bony structures or a vessel of like a sigmoid plate, the sound changes. So one should be very vigilant about this drilling techniques. And they also say the suction can be used as a guard while doing any drilling, like over a sigmoid plate. If we are going towards the posterior fossa dura, or we are drilling along the posterior canal wall, a suction can be used as a guard over the sigmoid plate and can prevent any injury which can be caused mainly by the shaft of the burr. And these all things, the basic drilling should be done under low magnification. It is suggested, and depending upon the structure like facial nerve, or if you are working in the canal, you can use the magnification, higher illumination. This is a basic which we should know before starting the drilling in the mastoid. So these are the gripping technique which I said. Now let's start we are ready with the basic rules. Now let's start how we will use the burr. the burr should always be in the contact of the bone whenever we are starting the drill, and the burr size and length we should assess beforehand, whatever the structure we are going to drill, and there should be a continuous movement, no break in a wider area and layer wise. So this helps us to get a wide space. We should never create a pit or a hole, because that will be dangerous, because the other important delicate structures or other landmarks are not visualized. And we should never exert any pressure, or minimal pressure is acceptable whenever we are drilling over the structures. And very important thing is, every structure which we are drilling, it should be along the long axis of that structure, like along the tegmen, along the sigmoid pit, along the axis of the facial nerve. We should never drill perpendicular to it. And we should always move from a risky to a safer area. For example, if we are doing a canaloplasty and we are coming along the superior or inferior canal, we should start from the medial aspect towards the annulus to the lateral aspect, because we have a more control in the starting of the drilling, and as compared to when we are coming out. That is, from the medial part we have more control as compared to the lateral part. Also, it holds well in the case of sinodural angle, which we should start from inside out. And copious irrigation should be always available, whether whatever structures, whatever burr we are using, more in the case of diamond, as I told. And one must be careful about the ossicular chain portion, because in every time a drill, if touches the ossicular chain, it will lead to SNHL, and it's an unforgivable mistake actually. And the shaft, we should be aware the length of the burr, we should decide accordingly, and we should be aware that which structure we are doing drilling, and the shaft is touching anything, like in a facial recess, any facial nerve is getting contacted with the shaft of the burr. We have to be careful about this. So these all burr tips for the usage of burr we should keep in mind. Now let's start the drilling. Before every mastoid surgery, a canaloplasty is must or essential, which is followed in our hospital especially. Canaloplasty is nothing but it is providing a adequate and a normal contour to the external auditory canal. You can see in this picture, it's a very narrow canal, and to gain a proper exposure and to get the proper surgical results, one should be able to see the complete annulus. The white thing which you are seeing here is the cotton ball, is actually aluminum sheet which is taken up from the suture material covering, and along with that a cotton ball is kept here, and it is protected. The TM flap is protected, and we are getting ready for the canaloplasty procedure actually. Why it is required? Because it provides us a good adequate surgical exposure, good visualization of the important medullary structures. The good cicatrization and aeration is also achieved in the postoperative period, and the cleaning is also adequate if the canal is adequate, and the sound transmission is also better, leading to further hearing improvement in case of a surgery we are performing, especially for hearing, if in the cases of inactive diseases. So we should do the canaloplasty until we are able to see the complete annulus, and we to the limit where we don't have to move the microscope to and fro to adjust and see the annulus. So the canaloplasty is started from the lateral aspects of the canal, the lateral bony aspect of the canal. The posterior wall is drilled first, and then the superior wall and the inferior wall. And one must, as I told, we should always drill along the axes. Like in this case, if we are drilling the posterior canal wall, one has to be parallel to the annulus, or you can say superior to inferior direction. So this is the left ear of the patient. We are going to perform a canaloplasty, and we are going to start from the posterior canal. So a large cutting burr is taken, 6 or 7 mm, with appropriate copious irrigation system, suction irrigation system, and drilling is started in a parallel fashion. Let's see that. So you can see drilling is continuously done in a parallel fashion with a continuous irrigation system along the annulus. You can see along the direction of the annulus, or in a superior or inferior direction. one must be careful about this posterior canal wall drilling part, as we can expose the mastoid air cells, and this can lead to mastoidocutaneous fistula in the postoperative period. So in case of a pneumatic mastoid, or even in sclerotic mastoid, if air cells get opened or communicate with the canal wall, one must not forget to close the cavity or at the end of the procedure, either with the fascia, periosteum, skin, whatever suits you. And then we should proceed along the superior and the inferior canal wall. See, here the drilling is proceeded from the medial to lateral inside out aspect, because this is the safer access. The safer access on the posterior wall was this, but on the superior wall and inferior wall will be this. And always from the risky side, that is towards the annulus is the risky side, and away is the safer side. So we should come like this, always outside. One must be drilling the tympanosquamous suture line in this anterior canal, and one has to be careful about the near the annulus. One has to be careful regarding the lateral process of Peleus. So when this drilling, we have started with a cutting burr, but as we go towards the towards the annulus, one can switch on to the diamond burr, a medium-sized diamond burr. And similarly, the drilling is continued here in the inferior canal wall, and on the anterior canal, one has to tilt the patient, and one has to be very careful because the anterior canal is very thin and can easily expose the temporomandibular joint. And if the capsule is exposed, then unnecessary jaw opening problems will be there, and movement of this jaw can affect the healing in our tympanoplasty surgery, and even the graft can get lateralized. So anterior canal wall, one has to be careful. Posterior canal, even towards the annulus in the posterior canal wall, one has to be careful in the posterior inferior quadrant about the facial nerve, because it lies lateral or approximately 2 to 3, sometimes in 2 to 3 millimeter lateral to the annulus, and one can easily damage this. So one has to be careful in these areas. And the ossicular chain, we should carry out canaloplasty to achieve good results, good graft intake, good surgical results, and it is an essential surgeries before every mastoid surgery. So let's start drilling over the mastoid. After canaloplasty, one has to know the basic things, like when we are drilling a mastoid cavity, mastoid cortex, we should not give unnecessary complications like damaging the soft tissues, ear canal flaps. It can happen if we are not holding the drill. The basic drill holding techniques matters here now. Like if across the edges we are drilling, one should never be tangential, because if you are tangential towards across the edges of the bone, then you tend to slip, because we are using a larger size burr, always safer, larger size burr, efficient removal, as I said, lesser penetration, but you cannot stop it from slipping, and it can cause unnecessary damage to the temporalis muscle, to the ear canal skin flap if you are drilling over the posterior bony canal. So across the edges, how we should hold the drill? It should be perpendicular. So when you are drilling across the edges, we should be perpendicular, and this unnecessary soft tissue damage can be avoided. In the ear canal, if you are drilling, like in the canaloplasty, where say I told in the previous slide, some surgeons, they prefer to remove the entire ear canal skin, or they say we should use the diamond burr within the vicinity, and also we can push the skin flap and the anterior angle, or we can protect it with the aluminium steel for this suture material. We can prepare a suture material and aluminium cover with the cotton ball. We can protect the skin flaps. Also, retractor blade can also help. So whatever suits you and whatever burr is your choice, you can use, and we should protect the soft tissues, and we should not let these all simple mistakes compromise the surgical results. So let's start with the drilling of the tegmen. After appreciating the McEwan's triangle, which we all know, superiorly the linea temporalis and this the drilling is started in the McEwan's triangle along the linea temporalis. We should always use the largest cutting burr, and it should be parallel. See, the axis of this Tegmen will be like this. So we have to be drilling in the anterior posterior direction with minimal or low pressure, and there should be a copious amount of irrigation and suction. And one must be vigilant that any pinkish structure, if visualized, then we are close to the dura. That means the dural vessels, they impart a color, a pinkish color, and we have reached a stage where the Tegmen is appropriately exposed. In some cases, the exposure of the Tegmen cannot be achieved properly. So, means if we are not sure about the exposure, the author says, Professor Mirkoto especially, that we can expose the dura. A small bit of dura can be exposed in a lateral part, and to that limit, we can expose the Tegmen, because exposure of the Tegmen is very important, a wide exposure for opening the antrum and see, which can happen to the lateral semicircular canal or the geniculate ganglion if the space is very narrow. So the Tegmen, the skeletonization of the Tegmen is very important. And if we are not able to carry out, we can expose a small part of the dura in a lateral aspect. So after drilling the Tegmen, there are certain situations like if it is a low-lying dura or attic cholesteatoma and we are not able to expose the complete Tegmen or not able to clear the disease, in those cases, we have to expose a larger portion of the dura, and one must not hesitate to do it, because the dural defects are very easily manageable with a CSF leak or without a CSF leak, but the disease clearance is very important. So one must drill or thin out this low-lying dura, and you can see in this picture a diamond drill, or you can use a diamond or a cutting burr, whatever suits you, but with no minimal pressure along the axis, under proper visualization and a suction irrigation system. In this picture also you can see this part of the bulging part or the low-lying part is aimed for drilling. And once it is drilled, the dura is exposed. One must be vigilant that the dura is not breached and the dura is intact. And then this dura can be pushed with the help of a blunt instrument like a suction tip. And we can clearly pass through this low-lying dura part and we can clear the attic cholesteatoma. So this is the situation where we have to deliberately expose the dura because we have no option, but we have to clear the disease. But even if we don't have an option, we have to delineate the Tegmen mastoideum in order to avoid any complications which we can get while opening the antrum. So this is the final picture when this is the dura and we have cleared the disease. This is a significant defect. It can prolapse also. So we have to repair it, which we'll study in the coming slides. And you can see the disease is cleared. Similarly, you can see the disease is cleared. And this is the portion of the exposed dura, which is intact. Damage can happen to the dura when we are drilling or we are skeletonizing the low-lying, the dural plate. When we are using a small burr, as I said, small burr, they have a more penetrating kind of tendency. Or if we are pressing too hard, then they can damage the dura, or we are pressing on the excessive pressure on the edge. Dural breach should not happen. It's an unnecessary complication. But if it happens, it can be manageable. So how to avoid dural lesions when we are skeletonizing the mastoid tegmen? So we should give an extensive lateral exposure. We should delineate the bone, the tegmen properly. We should use a large cutting burr, and across the bony edges, we have to be careful. As I said, no lesion should happen around it, damage to the soft tissues. If a large burr is used, pressure is usually less, but we should avoid any extra pressure over the burr. And we should drill in a continuous layer. Any irregular or discontinuous or bumps should not be there when we are drilling over the tegmen. And we should always use the side of the burr. Drilling should never be done from the burr head, because it will block the vision and it's not safe because it's not visualized. The head of the burr is usually not visible. So side of the burr will be the best to give an efficient clearance of the tegmen cells with a constant irrigation and in a slow manner. So wider exposure is achieved and dural lesions can be avoided. So now we have drilled the dura. the mastoid tegmen is exposed. And now we can proceed to the next step, that is to the sigmoid plate. The sigmoid sinus exposure.
One minute, ma. Let me unmute you. There was some disturbance. Okay, you can unmute.
Okay.
Yeah.
So after the tegmen being skeletonized, let's proceed to the posterior limit, that is the sigmoid sinus plate, which has to be drilled out. Routinely, we expose the peri-sinus cells by drilling across the axis of the sigmoid sinus, but we never deliberately expose the sigmoid sinus. What are the situations when we have to expose the sigmoid sinus? Like if we are not able to clear the disease lying medial to the sinus, like a cholestotoma. Since if cholestotoma causing lying medial to the sigmoid sinus, eroding the posterior fossa dura, or if we are planning for a translabyrinthine approach, a lateral skull-base surgery for vestibular schwannomas or endolymphatic sac surgeries, in those cases, we have to work medial to the sinus. In those cases, we have to drill out after skeletonizing, we have to expose the sigmoid sinus and to push the sinus behind so that we can work in this medial space. Otherwise, for a routine mastoid surgery, skeletonization and the clearance of peri-sinus cells in as per the rules will give us good results. So we have started drilling from the sinodural angle, the posterior limit where the tegmen exposure has reached, and we are drilling now in an inferior direction along the curvature of the sigmoid plate. Keeping in mind, we are using the largest possible burr, 6 or 7 mm burr, and cutting burr with the drilling with the side of the burr along the axis of the sigmoid plate with the copious irrigation system with minimal or no pressure. And the cells are excentrated when we have to go towards the tip. So once we are done with the clearance of the cells or the disease from the sigmoid sinus plate, we have to decide whether we are able to proceed with the medial disease clearance or not. If we are able to clear the disease, a limited disease on the medial aspect of the sigmoid sinus or sigmoid plate, then the sigmoid need not be exposed. The complete bone removal is not required, and we can proceed to the Antrum exposure. But if the disease is not significant, means not handled in a way to to remove it, we have to expose the sigmoid sinus. Like if the sigmoid sinus is very anteriorly placed and we are not able to remove the attic-cholestotoma which is lying beneath it on the medial aspect, then we have to expose the sigmoid sinus because we cannot achieve in an angulated way the clearance from this part. So you can see once we have drilled, I'll tell in the future slides how we will expose the sigmoid sinus. But once we have exposed the sigmoid sinus, we can push it posteriorly, and so we get access to the disease clearance on the medial aspect. And this can be held with a blunt instrument, and then the further posterior fossa plate can be drilled out and the disease can be cleared. So these situations where we require the clearance in the medial aspect, we have to expose the sigmoid sinus. So what are the methods which we can adopt for exposure of the sigmoid sinus? There are 3 broadly designed methods: the Bill silent method, eggshell method, and the total exposure method. What is a Bill silent method? It was designed by Bill House, when he was performing a translabyrinthine surgery, and he has to expose the sigmoid sinus so as he can push it behind and can proceed translabyrinthine route for the surgery for the lateral skull base. So he so in this technique, we have to first, as per Bill's, we have to first skeletonize it to a level to make it very thin, approximately 0.5 millimeters, and with a diamond burr. As we know, we are drilling across a very delicate structure and it can lead to profuse bleeding. So after making it very thin, we should switch on to a small size burr of approximately 2 millimeter, and one island of bone is drilled across the most prominent part of the sigmoid plate. And this island of burr is drilled to the depth where we can see the sigmoid, covering of the sigmoid, and it is done all over the circumference of the most prominent part. And after this, a blunt instrument can be used to fracture this island in posteriorly, and so this sigmoid sinus is protected, and we can expose or drill out the surrounding bones anteriorly, superiorly, and inferiorly. So this sigmoid sinus is not in the way of performing any lateral skull base surgery or any endolymphatic sac surgery, or in the case of any medial exposure, medial attic cholestoma, which is there, attic cholestoma extending medially, to the sigmoid plate. But there are limitations for this Bill's Island method of exposure, because one has to be very careful while we are making this small groove. We can directly injure the sigmoid covering, and when we are pushing it posteriorly, sometimes a tilt of this bone can at the edge can damage itself. Itself can damage the sigmoid. So we have to deal with the complications unnecessarily. So another method which was designed for the sigmoid sinus was the eggshell method. In this, a large diamond burr was used for making the sigmoid plate extremely thin, to the limit where it cracks into, where the periosteum cracks into kind of shells. And these are so thin that they are easily compressible. And so the same thing, we are compressing the sigmoid, which is now very thin, and we can drill out the bone anterior to it, superior to it, and we can clear the disease. So you can see we are proceeding, we are protecting the sigmoid, and we are drilling the bone, and we are clearing the disease after that. But it also has a disadvantage that the fracture segments, they can even tend to damage they tend to fall, and they can, in the further steps of the surgery, these parts can get damaged with the burr if we are going in the lateral skull base. Or these small sharp edges, they can itself damage the sigmoid and can lead to unnecessary bleeding. Another exposure method is total exposure. Sinus should be totally exposed only in certain situations which I described previously, and this is adopted when sinus becomes accidentally exposed in one part during drilling. So one has to do the same thing. We have to displace and protect the sinus using a blunt instrument and avoid any contact with the instrument, and we can carry on drilling the further sigmoid plate, right? Like in this picture, you can see here, the sigmoid plate got accidentally exposed. So the blunt instrument is used and it's protecting the sigmoid sinus, and rest of the sigmoid plate is meticulously drilled away. It needs a very good training skills for this total exposure of the sinus. Otherwise, we can lead to damage to the sigmoid. So you can see we have drilled completely. After completely drilling, we can push it posteriorly, and the anterior bone towards the posterior fossa we have to drill, and the disease can be easily accessed if we have drilled all this area, and we have also protected the sigmoid plate. So in case of a translabyrinthine approach, like the lateral skull base approach for acoustic neuroma, we have to drill it across the inferior part as well, towards the tip area. We have to continue drilling. We have to expose it. Even in the endolymphatic sac surgeries, we have to expose the inferior part till the dura. This is the posterior fossa dura. So we can drill and expose the bone so that the sigmoid sinus and dura is exposed, and we can protect these both with the help of a blunt instrument, and we can see the endolymphatic sac, and we can proceed with the surgeries. Is there a need for total posterior fossa exposure, complete exposure? Posterior fossa dura, it's usually not required, but in cases like extensive cholestoma, which is causing erosion or damage to the dural plate, posterior fossa dura plate, in those cases, sometimes we have to drill or to remove the complete fossa plate, because the edges of the erosion can have some remnant cholesteroma matrix. So one has to expose the sigmoid, one has to posteriorly push the sigmoid, and one has to expose the posterior fossa plate, the bony plate, and we have to drill and remove all the cholestoma matrix so that the disease is not recur in the future. So same thing after doing the after exposing the sigmoid, we have to expose the bone anteriorly, and you can see the posterior fossa dura coming in picture, which is also saved with the help of a blunt instrument, and the bone is kept on drilling, and so we can expose the posterior fossa dura and we can proceed. Sometimes a bony tag can be remaining, which can be drilled or removed with the help of freers. And also, if a cholestoma is involving a perilabyrinthine space, then also we have to drill and remove completely the sigmoid plate and the posterior fossa dura plate. Then only we can access the perilabyrinthine cholestoma extension, as you can see in this picture. So these cholesteatomas or these procedures like translabyrinthine exposure for acoustic neuroma or endolymphatic sac surgeries, they have a different approach. It was also discussed in the last class for the lateral skull base. I'll just give a quick revision that we have to give a large posterior flap, approximately 4 centimeters behind the retroauricular groove, and including the muscle superiorly, anterior muscle temporalis, and inferiorly some of the splenius capitis and transverse nuclear muscle, and we have to lift this flap anteriorly, and then we get quite a big area for the exposure of the posterior fossa dura, and we'll continue same in that way. We have to expose the sigmoid sinus, protect it, and then drill out the posterior fossa bony plate, protect the posterior fossa plate also, and we can access the disease or a translabyrinthine surgery or endolymphatic sac surgery in this way. And now after this all, we have to, after the sigmoid is dealt with, the disease or all the conditions we have handled, let's enter the mastoid antrum. Mastoid antrum, it's must for every routine case of mastoid surgery. In this, we have to use a medium size cutting burr, and we should start from a posterior superior cell, especially a posterior superior cell in relation to the corner septum, and which is usually a wide cell, and we can expand it or drill it, and we can proceed anterior superiorly. In case of a pneumatized mastoid, it's very easy to open up the antrum, but if the mastoid is not pneumatized and the tegmen is low, in those cases we have to be careful regarding the choice of the burr which we are using and the damage which we can give to the structures which lying immediately next to the antrum or in the adductus part, we can say. So we have to drill parallel to this mastoid tegmen in an anterior superior direction, and we can proceed along the posterior fossa dura as well, excentrating all the cells, and we can easily open the antrum in that way. And at the end of the cortical, at the end of the opening of the antrum, we can see important landmarks like the lateral semicircular canal and the fossa and the short processus incus, and we have to now proceed with the further clearance of the cells of the mastoid. A disease from the sinodural angle is not always required unless it's a cholesteatoma or an aggressive disease like that. So usually these cells, they are very small in size, and inside out drilling is sufficient enough to, with a small cutting burr, is sufficient enough to clear the disease, and further smoothing can help to clear the sinodural angle. And the structures, the most important structure, that is the superior petrosal sinus, which is lying in relation to this, is usually not involved. But one has to be careful about the vessels like the emissary veins, which is there in the angle. And in the cases of cholesteatoma, there is erosion of these bony plates, the mastoid fossa, middle canal fossa plate and the posterior canal fossa plate. These are dehiscent. So in those cases, the removal of the cholesteatoma has to be very precisely and delicately. Same, we have in these pictures also, we can see the exposure, the cholesteatoma matrix, which is lifted from the sinodural angle. And here we can see the superior petrosal sinus coming in picture. It's usually not seen unless the bony plates are eroded. Okay. So let's start the mastoid tip cells exentration. Now we have drilled across the sinusoidal angle, the tegmen, the mastoid, the antrum is open. Now we have to proceed towards the mastoid tip. A mastoid tip usually in a limited mastoid pneumatization, we can drill till the extent we can find the mastoid cells, tip cells with the large cutting burr in a smooth fashion like superior to inferior direction with a continuous irrigation. And if the pneumatization is limited, then we should not go till the tip of the mastoid, and we can stop till the last limit where we can see the cells. But in cases of extensive pneumatization, sometimes it goes beyond the mastoid tip, like it can expose the digastric ridge as well. So we should clear the disease, but we have to be careful regarding the facial nerve, which will be present here anterior to it. So we should clear the disease till the mastoid tip, exentrating all the cells in cases of extensive pneumatization. Now, after this all clearance, let's clear. It's routinely facial nerve is not exposed in any of the mastoid surgery. Only perifacial cell clearance or skeletonization is done in any mastoid drilling, and one must remember the segment, the mastoid segment. The anatomy should be perfect for the mastoid segment part, so that we should not damage inadvertently the facial nerve. So before drilling, I want to just review the anatomy of this mastoid part of the facial nerve. We can see the second genu, which lies just medial to the short process of the incus. And also behind the pyramidal process, this second genu, it turns and it forms the mastoid part of the facial nerve. This mastoid part of the facial nerve in the superior part, it is related, or the landmark is the horizontal semicircular canal. So it lies inferior and medial to the anterior and medial to the horizontal semicircular canal, and to the posterior semicircular canal, which will be here. Approximately 2.5 millimeter of distance is there. So these are the superior landmarks for the mastoid segment of the facial nerve, and this facial nerve then follows the same course as the posterior canal wall. And in the lower part, the mastoid, the digastric ridge, it is the important landmark, and the facial nerve lies anteriorly and medial to the digastric ridge. And in this part, the facial sheath is fused with the periosteum of the digastric muscle. So let's skeletonize the perifacial cell. One has to be careful regarding holding of the drill. We should use, first of all, a diamond burr and a medium or a small size diamond burr in a direction that it is pointing towards the middle ear space and not towards the perpendicular towards the facial nerve. So this is wrong. We should be towards the middle ear space, and we should start drilling from the fossa inquiris, just below the fossa inquiris, along the curvature of the posterior canal, and we should proceed towards the tip. So the perifacial cells which are found should be cleared, and keeping in we should be vigilant about the exposure, any subtle change in the color, and we should not go expose the facial nerve in any cases until it's indicated, like facial nerve decompression or any other situations like that. This was all about the drilling techniques, a basic drilling techniques of the mastoid. Now let's start with the hemostasis, as it is required when we are drilling various structures, and we can damage, or we can inadvertently, or sometimes with a wrong choice of the burr, we have to handle situations like in a soft tissue damage. We can use a monopolar or bipolar handy, and it can usually stop the bleeding points, and even a Surgicel can control the soft tissues bleeding. On a bony surface, diamond burr, as I told, it seals the surface, it transfers the bone dust across the lumen, and it causes the hemostasis. Even the heat transferred by the diamond burr can cause the hemostasis, and bone wax on top of that can also help on controlling bleeding in a bony surface. Any mucosa, like in the middle ear cavity, if we are working from the TM flap or in the mucosa, if the bleeding has to be controlled, we should never use any coagulation methods, only the gelatin sponge or cotton balls which are soaked in the local anesthesia solution. They are very good to control the bleeding. and provide a good exposure for the surgery. For the fossa dura, like the middle canal fossa and the posterior canal fossa, bipolar coagulation works well. We should avoid using monopolar cautery, especially in these areas, because it can cause perforation more. And the jugular bulb, Surgical works very well for any injury over the jugular bulb in the either in the mastoid or the middle ear. But if we are using bipolar coagulation, we have to be very low power. And once if we are able to, one attempt should be done for the coagulation, not multiple attempts. Otherwise, it causes more tear of the delicate structure like jugular bulb. So let's start with the dura. When we were drilling on the tegmen, we can get some dural tears, or we have to expose a small part, as told by Professor Mirkotos, in order to skeletonize the mastoid tegmen. So those small tears, sometimes they heal on its own, but it can have a tendency to prolapse, as we know, because the dura is exposed. So we can just with the help of a small curved bipolar, the edges we can bipolarize, coagulate, and so it can easily close. But sometimes if you feel that it's not enough, a TM flap, a temporalis fascia can also help to strengthen it. In case of larger defects, like in case of a low-lying dura and low-lying tegmen, and we have to expose the whole tegmen part, and we have to clear the disease immediately. So those type of defect, they have a tendency to get prolapse, and they can have a CSF leak. So we have to close them. And for this, we use a triple seal. Triple seal involves the first, and this defect has to be first addressed with the help of a fibrin glue. And this fibrin glue is placed like a cotton, like a cork. A small part is placed in the center and surrounded by another layer, or on the periphery, the fibrin glue is placed, and the harvested temporalis fascia is then tugged on the surface beneath the edges of this exposed bony defect. And after tucking this, and there was a this fibrin glue beneath it, on top of it, the third layer, that is the fibrin glue, is again placed. So this 3-layered closure is significant enough to not to cause any future problems. If in case there are significant CSF leak along with this large defects, then we should use some more tougher substance, like we can harvest a cartilage, a conchal cartilage or a tracheal cartilage, and we can tuck the tracheal cartilage inside. And after that, we can put a layer of this fibrin glue over it. And again, we can put, this is a cross section. So this is a defect. We have tucked the conchal cartilage inside. Then we have put a fibrin glue. Along with, we'll try to give a support of temporalis fascia. And on top of temporalis fascia, again, we can give a fibrin glue. And so it closes that defect with CSF leak in a proper way. Now let's deal with the sigmoid sinus bleed. Sigmoid sinus bleed can vary from a small to a large lacerations. If a small hole, it can be dealt with a small surgical, and the surgical with supported with the help of a this gauge piece and a blunt instrument. It usually settles the small hole, the bleeding from the small holes. In case of a small lacerations, we can use a curved bipolar tip, and usually it controls the bleeding as it coagulates the end, and so they get adhered to each other, and the laceration stops bleeding. In case of an occipital vein, which is seen on the medial aspect of the sigmoid sinus, this has to be, it depends. If it is bleeding from this side, we can cauterize or coagulate with the help of a bipolar. And this end, if it is just at the level of the bone, then it needs a bone wax. But it can be easily manageable. It's a small vein. In case of large lacerations, especially when we are doing this exposure of the sigmoid sinus, they need obliteration. It can be extraluminal, intraluminal, or both. So let's see what is extraluminal. It means above the lumen, we are trying to put or pressurize, and we are obliterating this. So in this, first we have to put a surgical, and by that time, just in this picture, we are seeing this gauge piece is held and pressure is applied over this, and after some time, the surgical is placed and it is tucked in to the bony edges throughout the length of the sigmoid sinus. And then we can, even if the bleeding stops, it's good. If it doesn't stop, another layer of surgical we can place and tuck it, and some external pressure for some time, it's good enough for medium size of lacerations, and this is all about extraluminal obliteration. In cases of the bleeding, which is not even controlling, even after the means there are significant laceration, larger lacerations, we have to do obliteration of the lumen. Again, we can use a surgical. The major part of the surgical lies outside, and a middle and a significant part is folded in the form of a ball or a chunk, and it should be blocked. It should be blocked into the lumen of the sigmoid sinus, and external pressure should be applied, and over it we can even apply a surgical and tuck it under the bone. So this is intraluminal obliteration, but one has to be careful that it should not become an embolus. That's why the external part, a large external part, is kept outside, or it is tucked, you can say, in the bony edges at the margins. Sometimes we have to do both. Even after obliterating this large defect with the surgical, a large part has to be covered, which is on the outer part, has to be covered and with an additional layer of surgical, and it also provides a good obliteration. Then it is done both ways, intraluminal and extraluminal. Even if it's even after this all intra, if the bleeding doesn't stop packing the lumen pressure, then we have to ultimately go for IJV ligation. We have to open the neck, explore it, and IJV has to be ligated. Last will be the bleeding from the superior petrosal sinus. It is rare, and because the superior petrosal sinus anatomy is not that it's very superficial. It is on the medial or the posterior aspect of the sigmoid sinus. So unless there is aggressive disease in the sinusoidal angle eroding the bony plates, the sigmoid sinus, the superior petrosal sinus is not exposed, and it doesn't cause any bleeding also. So in cases of small bleeds of the superior petrosal sinus, a cautery can be beneficial, and surgical with external pressure, even the obliteration, external obliteration, internal, if possible, can help to control the bleeding. But if it's excessive, it's uncontrollable, then the ligation can be attempted. So how we are going to do the ligation? You can see this is the sigmoid sinus, and this is the superior petrosal sinus. The site of the bleeding is pressurized with the help of a surgical, and we have to suture, we have to ligate. But these two things, these are dura actually. So we can easily pass a suture across the dura in a distal aspect and the proximal aspect, and we can ligate this superior petrosal sinus bleed as the last attempt if nothing works as per the previous techniques which I told, that is the cautery, pressure, surgical. So we can control the bleeding by ligation also. That was all about my presentation, mastoid drilling and the hemostasis. These are my references. Thank you.